Good evening, my dear brothers and sisters. I am very, very happy to welcome all of you for a very interesting masterclass webinar series on hypertension. Actually, this program is sponsored by World Lung Foundation along with Whole Medical Academy. Slide is not moving. Slide is not moving. The World Lung Foundation is major aim and objectives, the areas of public health ranging from cardiovascular disease control and prevention to road safety, to environmental health, to civil registration and vital statistics. All public health related activities and the scope of the work cover comprehensive public health service. And of course, all of you know Whole Medical Academy, we are doing hundreds of webinars. Now, the objectives of this webinar series is to promote standardized care for hypertension that is evidence-based and aligned with international best practices. To plan, coordinate, and deliver 2 series of workshops on management of hypertension, focusing on private sector providers. The focus of the virtual workshops would be to promote standardized care for hypertension based on recent WHO hypertension treatment guidelines, to promote opportunistic screening for all patients over the age of 18, to reduce physician inertia to start and continue treatment of hypertension, to emphasize the importance of medication titration follow-up hypertensive patients, to ensure better blood pressure control, and also to make everyone to follow accurate BP measurement in diagnosis. And what is interesting here in this webinar is those who attend all the 5 webinars will get a certificate from World Lung Foundation and the Medical Council, Tamil Nadu Medical Council. We have already got credit points from Tamil Nadu Medical Council, those who attend all the 5 webinars. And also we are planning to give home blood pressure monitoring to all those who attend all 5 webinars and participate in Kahoot. We should not only participate in the webinar, we should also participate in Kahoot. Then that certification from Tamil Nadu Medical Council will be given after 5 webinars. And of course, today we are going to talk about diagnosis of hypertension. Dr. Chenniyappan and Dr. Manisha Sagai. Chenniyappan is the speaker and Manisha Sagai is the panelist. Chenniyappan needs no introduction, but still some of the new members have joined our program from various CVHOs, cardiovascular health assistants all over the country. So Chenniyappan is a consultant cardiologist, Ramakrishna Medical Center at Trichy. He is the senior consultant cardiologist, Apollo Specialty Hospital, Trichy, honorary professor of Indian Medical Association. He is an adjunct professor of Tamil Nadu MGR Medical University, honorary director of medical education, Apollo Specialty. He is also a distinguished clinical teacher, Apollo Hospital. He is a resource person at Public Health Foundation of India. He is an advisory board member of the Journal Association of Physicians of India. And not only that, he has done so many webinars, so many live programs, teachings, and he is one of the authorities of ECG. He has visited almost all medical colleges in the country. All PGs love to listen to him. And his teaching about ECG is remarkable, one of the world class. And he is not only in ECG, also in hypertension. We have together, myself and Chenniyappan in the same forum, we would have delivered around 30-40 webinars so far, especially in lockdown. And Manisha Sagai is a professor and head of the Department of Nephrology, Osmania Medical College, Osmania General Hospital, Hyderabad. Counselor, International Society of Nephrology, Chair, South Asia Regional Board, International Society of Nephrology, Editor-in-Chief, Indian Journal of Transplantation, Vice President, Indian Society of Nephrology, Fellow, Royal College of Physicians, Fellow, Indian Society of Organ Transplantation, Fellow, Indian Society of Nephrology, Committee Member, Sister Renal Center Committee, Committee Member, American Nephrologist of Indian Origin, Executive Member of the Indian Society of Organ Transplant. Not only that, he is a very good communicator, good speaker. You will really love to listen to him also. Now, coming to Kahoot, many of you are known about Kahoot and how we play Kahoot after Chenniyappan's talk. The steps for Kahoot is, type Kahoot.
You have to tell about your diet to everyone. Really, we had given talk unnecessarily to doctor.
Please type Kahoot in your laptop or mobile and be ready. We will give you a game pin number. Please enter the pin and your name. Then you can play. There are 10 questions. For each questions, we have given 20 seconds. Those who give correct answer early will also get more marks, and your participation is enough. Not necessary that you should qualify first, second, third, and all that. Your participation in Kahoot is enough. So with this, let us start. Thank you all for participating in our good webinar. Now I request Dr. Chennappan to share his slides. Today we have with us, apart from Chennappan, Dr. Manisha Sagai, Dr. Sangram Bradar is there, and Dr. Anupam is one of the consultants for our Resolve to Save Lives. He is there, and Megha Dubai, who is the organizer for this program, he is also there. So I have great pleasure in welcoming all of you. Now I request Dr. Chennappan to present his presentation. Over to you, Chennappan.
Good evening, sir, and I thank World Lung Foundation as well as Hold Medical Academy for giving me this excellent opportunity to talk to you about the diagnosis and screening of hypertension. So I make regards to Dr. Sangaram, Dr. Anupam, and Dr. Manisha, as well as the organizers of the World Heart Foundation program. So now, first of all, we must start by defining what is hypertension or what is blood pressure. Many of us do not know. We know a lot of things about hypertension. We must know what is the definition of blood pressure, first of all. The blood pressure is defined as a measure of lateral force. It is a lateral force exerted by the blood column, which is pumped by the heart per unit area of vessel wall. So it is a lateral pressure what we are measuring as the blood pressure. So whenever this pressure undergoes to a higher value, you diagnose a hypertension. So I don't want to bore you with all statistics about Indian statistics, how in India 1 in 3 has hypertension, 50% of people are waiting to become hypertension and so on. So you would have been bored by all these statistics. So I thought I tell you a very important paper which appeared in JACC in 2020, which ranked the modifiable risk factors to cause cardiovascular disease from most dangerous to less dangerous. There are 12 risk factors they have mentioned, and the first rank is held by the high systolic pressure. So the high systolic pressure is the most dangerous modifiable risk factor attributable to cause cardiovascular disease, by which you mean a coronary heart disease, peripheral vascular disease, stroke, and so on. And our famous diabetes comes under 7th rank. Although we hold many meetings and seminar almost every day, 2 to 3 webinars are happening. And I feel personally, the hypertension is the most dangerous risk factors, much more than diabetes, is not given its due importance. That's where Dr. Murunathan Services has come in, and his entire work on hypertension, education on hypertension, webinars on hypertension, are trying to create the much needed importance for this most dangerous risk factor of high systolic pressure. Then first of all, we look at the diagnosis of hypertension, then we go to the screening of hypertension. So we can diagnose hypertension in a variety of ways. I have listed some 10 ways we can diagnose the hypertension. First of all, we have to diagnose hypertension by correct methodology. So the correct methodology is one, the patient's preparation. The patient preparation is that he should not have been taking smoking, coffee, food, or exercise 30 minutes before. He must be sitting in the quiet room in a comfortable temperature. So you must take blood pressure after 5 minutes of rest. So when the pressure is taken, neither the patient should speak nor the doctor should speak. And most importantly, the patient should have an empty bladder. So this is the patient preparation. And then also the patient is allowed to sit in a comfortable chair where the back is supported and the legs are grounded and the legs are uncrossed. So the limb should be supported, and it should be, and the cuff you apply the middle of the blood pressure level of the heart. And of course, the cuff should be of normal width and length. Annual blood pressure monitor, which should be validated and correctly recording your blood pressure. So with this, what is very important is when you elevate and deflate your blood pressure column, the speed at which you deflate the blood pressure column should be 2 to 3 millimeters of mercury per second. And Korokos first sound is systolic blood pressure. Korokos sound 5 or disappearance is the diastolic blood pressure in adults, in children. And of course, if you continue to hear the Korokos sounds till 0, then you have to put a middle number at which the Korokos sounds are muffling. So you can have 3 readings when you continue to hear the Korokos sounds to 0. So this is the most important point. And I'm going to tell you that in many times in many clinics, we see the blood pressure is taken in this type of a stool, where there is a small aluminum top with the 3-part aluminum stool, where the patient is sitting and balancing. He is thinking when he is going to fall. His legs are not grounded and the back is not supported. So if you take the blood pressure from this type of sitting stools, you may have erroneous BP recordings. So the most important thing is about the bladder. The bladder width and the bladder length should be appropriate, for which you must know about the arm circumference. The bladder width should be 40% of the arm. The bladder length should be 80% of the arm. And you have to tie the arm 1 to 2 centimeters above the elbow fold. Many times you will be tying this this BP cuff on the elbow fold and trying to insert your stethoscope inside the fold. So that itself will create more Korokos sounds rather than your thing. So your stethoscope should be well away from the lower border of the cuff. And you have to use the correct cuff. So it is advisable to have 3 sizes of cuffs. One is for the children, and second is for an average adult, and third is for a large adult. So it is better to have all the 3 cuffs to get the correct blood pressure recording. Because when you use a small cuff for a big arm, you have highly elevated systolic pressure. If you have a large cuff for a small arm, your systolic pressure will be underestimated. There are 5 rights you have to follow to record the blood pressure correctly. The correct cuff size and the width and the length, and the right placement of the cuff, the middle of the cuff in the level of the heart, and the lower border of the cuff with 2 centimeters away from the elbow fold. Right position of the patient who sits with back supported, leg grounded, and also the arm supported. And the right preparation I told you about the smoking, coffee, sitting in quiet place, empty bladder, and so on. And most importantly, the right performance of the physician by elevating the blood pressure column and deflating the blood pressure column at the appropriate speed. And most importantly, here I have written and highlighted that all blood pressure should be recorded by the physician responsible for the patient. So this is, I am insisting that, because many times we believe the blood pressure recorded by paramedics outside and try to adjust our drugs. So however much patients you see, it is very, very important that you record the blood pressure in a right method. So these are the 5 rights to record the blood pressure correctly. And of course, when the arm is more than 42 centimeters, when your arm circumference is more than 42 centimeters, you have a conical cuff like this, which will accommodate the large part of the upper arm, and it will be narrow in the lower side. So you can have special cuffs for a very large upper arms. And of course, when the patient is sitting, as you can see, when the patient is in bed or trolley, ensure the patient is sitting, the legs are outstretched or uncrossed. That's a very important thing. When the patient is sitting, his back should be supported and the legs should be grounded, and the legs should not be crossing each other. And of course, when patient is sitting and your arm is little bit down, you have to put a pillow to elevate the arm to make sure the cuff you are putting in the upper arm is at the level of the heart. So that's why you have to make these adjustments if you have a table which is much below your center of the heart. Then of course, when you tie the cuff, make sure there is 1 to 2 centimeters from the elbow fold, so that the rim of the stethoscope should not touch the lower part of your blood pressure cuff. That's a very, very important thing, because this connection between the cuff and the stethoscope itself can produce an artifact mimicking echo sounds. And then, of course, when you are taking the standing blood pressure, once again, the cuff is in the middle part of the heart. And of course, you should not allow the hand to hang down. You have to make sure the hand is straight and held by a attender. And in this way, you have to take the standing blood pressure. So don't take a standing blood pressure with the hands are hanging down. So the hand should be supported like this, and then only the standing blood pressure should be taken. So these are some of the important methods by which we take the correct blood pressure. So when you take the correct blood pressure, how many readings you must take to diagnose hypertension? So the guideline says that you must take at least 3 measurements. Some practically it is advised when your blood pressure, first you are taking blood pressure and the blood pressure is less than 140/90, no further measurement is needed. You can use as the first blood pressure as your blood pressure. Whereas when the patient has got a BP of 140 and 90, more than 140/90, take the second blood pressure reading and take the second blood pressure reading as the patient's blood pressure. And if there's a difference between the first blood pressure reading and the second blood pressure reading is more than 5 millimeter, then take the third blood pressure reading and use the third blood pressure reading as the blood pressure of the patient. So this is how practically we can do 2 to 3 measurements to diagnose blood pressure. Then very important thing is, once you diagnose hypertension, then the pharmacological treatment should not be delayed more than 4 weeks. So once you diagnose hypertension, the treatment should be started within 4 weeks of the diagnosis. But please make sure this is about 140/90. When the patient comes to you, pressure of equal or more than 160 and equal or more than 100 diastolic, and there is an end organ damage, there should not be any delay in starting the treatment of the patient. So the patient should be initiated antihypertensive almost on the same day. So this is how you diagnose blood pressure and start the treatment. So what happens when you do not follow these important methodology of recording the blood pressure? If you are talking or the patient is talking, the blood pressure will increase by 10 millimeters of mercury. If you are talking, the blood pressure can increase by 5 millimeters of mercury. If the patient crosses legs, it can increase by 8 millimeters of mercury. I told you about the stool. If the patient is sitting on the stool, and the pressure can go up to 10 millimeters of mercury. When the arm is not supported and the arms are hanging, systolic blood pressure can go up to 7 and diastolic to 11. And the arm is not positioned at the center of the heart, it can go about more or equal than 2 millimeters of mercury. This is the most important thing. Every time the patient is sitting in your AC waiting hall and come to you with a full bladder, he can have a blood pressure of more than 15 millimeters of mercury. And of course, he is taking coffee recently, 10/5. Yes, smoken recently, 6/5. And very, very important, cough over clothing can increase the blood pressure up to 50 millimeters of mercury. So that's why the arm should be without any cloth. If I told you already, when the cuff is too small, the systolic pressure may increase, even the diastolic pressure may increase up to 2 to 8 millimeters of mercury. So you can see how much wrong you can be if you are not following the correct method of blood pressure. So many times you are wrongly will be diagnosing hypertension because of the wrong method of measurement of blood pressure rather than true hypertension in the patient. Then, of course, to eliminate white coat hypertension in sprint trial, they have done what is known as automatic unattended clinic BP recordings. So here, the patient is put in a separate room. The blood pressure cuff and the positions, all these things are followed. The blood pressure cuff is connected to an automatic oscillating blood pressure apparatus. And once you leave the room, then the paramedics or the health personnel leaves the room, then the patient is alone. After 5 minutes of sitting, this BP machine will take one reading. Then it will wait for 1 minute and take another reading. And then it will wait for 1 minute, then take another reading. So the 3 readings are taken by the machine in whom the patient is alone and there is no health personnel inside the room. And the machine automatically takes the average of these 3 readings and give you the average reading. So this is the method followed by a sprint trial to get the correct hypertension, especially when the patient is supposed to have white coat hypertension. But the important thing you have to understand is the diagnosis threshold of this type of method is not 140/90, it is 130/85. So whenever 135/85, if in this method, if the patient has got blood pressure of more than 130/85, he is supposed to have hypertension, and it is not 140/90. So having diagnosed the hypertension with the correct methodology, we come to diagnose by numbers, which is the most confusing thing. So if you look at the various guidelines, you will get totally confused what is hypertension. So each guideline will give you a number, and each guideline will tell you there are 2 grades, there are 3 grades, and there are 4 grades, and so on. So it is better to follow a single guideline for uniformity. So I thought, this is my personal opinion, this International Society of Hypertension Classification 2020 is very simple to follow, because normal blood pressure is less than 130/85, and high normal blood pressure is 130 to 139, and diastolic of 85 to 89. You diagnose hypertension when the BP is equal or more than 140 systolic, or equal or more than 90 diastolic. So that is a grade 1 hypertension. And anything systolic pressure equal or more than 160 and diastolic equal or more than 100 comes the grade 2 hypertension. So only 4 things you have to see: normal blood pressure, high normal blood pressure, grade 1 hypertension, and grade 2 hypertension. It is very easy to remember and very easy to follow in our day-to-day practice. Of course, we have guidelines from our own API with the Indian guidelines of hypertension, European Society, American Society, and so on. But for a uniformity, you have to follow a single guideline which you like or which you are familiar with. My choice is International Society of Hypertension guideline. There are other forms of hypertension. So this is systolic and diastolic hypertension. Whereas it can be an isolated systolic hypertension when the systolic pressure is more than 140, with the diastolic pressure is equal or less than 90. It can be a high pulse pressure hypertension, where systolic pressure is more than 140 and the diastolic pressure is less than 70. It can be isolated diastolic hypertension when the systolic pressure is equal or less than 140, but the diastolic pressure is more than 90. It can be a hypertensive crisis whenever the BP is more than 180 systolic and diastolic more than 120. So these are the other forms. So there are many forms of hypertension you can diagnose depending upon the systolic pressure and the diastolic pressure and the pulse pressure and so on. So these are the other types you can diagnose by the numbers. So you will get confused. So when so much things is there, how should I start a treatment? So to start a treatment, what will be the practical method will be, whenever the patient has got a BP of equal or more than 130/80, if the patient has got coronary heart disease, heart failure, CKD, diabetes mellitus, and cardiovascular risk score estimated by ASCVD risk score more than 20%, and the patient is less than 65 years, the threshold of starting antihypertensive treatment is 130/80, because these are high risk groups. In these high risk groups, the threshold of starting the antihypertensive should be 130/80. And of course, even the patient is above 65 years, if the patient is very healthy, very active, independent, you can try to start the antihypertensive treatment at 130/80. The threshold of starting the BP treatment at 140/90 in patients who are post-stroke, who have got a low risk patients who are more than 65 years, and although they are less than 65 years, they are multiple comorbidities, they are frail, they are non-independent, intolerant, then the threshold of starting the antihypertensive treatment should be 140/90. When the patient is above 80 years, the threshold of starting the antihypertensive should be more than, equal or more than 150/90. So when you look at this age, although I have given you the chronological age of 65, so please try to depend upon the biological age rather than the chronological age. By that I mean, a patient with 70 years may be very active and independent, then your goal can be 130/80. But a patient with 55 years with a multiple comorbidities and frail, then your goal should be 140/90. So this age is not a very strict numbers, but depending upon the patient. So having started the treatment, what is your target? In many of the patients less than 65 years, your target is to achieve the blood pressure of less than 130/80 and not below 120/70. So that is the threshold. Whereas in patient more than 65 years, it should be less than 140/90. Of course, I told you, if the patient is very active patient above 65 years, you can just aim at 130/80 also. But at what time frame you have to get this target after starting the treatment? The time frame is within 3 months. So this is the threshold of starting treatment. And of course, this is a target to be achieved, and it is a time frame in which you have to achieve the target. So this is regarding the number. Then we look at the diagnosis by etiology. By etiology, by mean whether you have an etiology or no etiology for hypertension. If you have no etiology of hypertension, it's called primary hypertension, where there is no correctable cause to cure hypertension. So primary hypertension is only controllable hypertension. That's why there is a lifelong drugs, lifelong lifestyle modification in primary hypertension. Whereas in secondary hypertension, most often curable hypertension, because if you are able to treat a secondary cause, the blood pressure may become normal and it can be a curable hypertension. But nowadays we see the third form, which is not extensively described in the literature. It is not the primary, secondary hypertension are not in the individual compartments. Many times we can see that the primary hypertension patient for a long time, they may develop a secondary cause subsequently, and there will be a combination of primary and secondary hypertension. So this is a combination hypertension. So this is where your patient who has got well-controlled blood pressure will suddenly go out of blood pressure control because of an additional of a secondary cause. So these are the three important blood pressures according to the etiology, whether it is primary or secondary or the combination of primary and secondary. So when you want to dissemble, when you want to remember the commonest, I'm telling you the commonest cause of secondary cause of hypertension, I wanted to remember not Obama, but what he is dropping, the drop it. The D stands for drugs and diet. R stands for renal. It can be a parenchymal disease or renovascular disease. O for obstructive sleep apnea. P stands for primary hyperaldosteronism. I stands for inequality of pulses. It can be coarctation or aorta arteritis or a peripheral vascular disease. And T for thyroid abnormalities. These are the 6 important commonest causes of secondary hypertension. So if you suspect a secondary hypertension in any patient with hypertension, you have to rule out these 6 important causes, which are the most important causes of hypertension, because as you can see, many of these secondary hypertensions are curable. If you take out a drug which causes hypertension, you are curing hypertension. You are controlling the renovascular disease, you are curing the hypertension. You are giving a CPAP, you are curing the hypertension. You treat hyperaldosteronism, you are curing hypertension. You relieve coarctation, you are curing hypertension. You thyroid hypertension. That's why the first step is in any hypertension, before diagnosing it as a primary hypertension, it is important to rule out correctable cause of hypertension. So what are the clinical clues to suspect secondary hypertension? Any difficult to control hypertension, we are using 2 to 3 drugs, the blood pressure is not coming down, suspect secondary hypertension. Onset of hypertension before 30 years. Onset of diastolic hypertension after 65 years. After 65 years, you expect systolic hypertension and not diastolic hypertension. The blood pressure of the patient last week was normal. Today, suddenly the patient has got blood pressure. Then you suspect secondary causes. This is what I told you. For many years, the patient was under good control of blood pressure. Suddenly, his blood pressure is increasing. Suspect a secondary cause which is coming into the patient of a basically primary hypertension patient. Hypokalemia, unprovoked or provoked with diuretics, suspect primary hyperaldosteronism. Accelerated or malignant hypertension or hypertensive crisis where the BP is more than 180, 120 and significant fundus changes. And disproportionate hypertension mediated organ disease to the degree of hypertension, claudication in young patient, coarctation of aorta, unexplained underlying hypertension, suspect CKD, daytime sleepiness and tiredness, suspect obstructive sleep apnea. And in all hypertensives, it is very, very important to go through the drug history. So many allopathic and other system medicines can cause hypertension. So this is how we suspect a secondary hypertension. So when you suspect a combination of primary and secondary hypertension, the most common cause of secondary cause superimposing on a primary hypertension is developing atherosclerotic renal artery stenosis, developing a thyroid disease, patient developing a hyperaldosteronism, patient developing a CKD and on treatment with erythropoietin, patient developing obstructive sleep apnea, new habits like alcohols, drinking and smoking, new drugs, especially drugs like ginseng and all the vitamins, the patient all the steroid or sympathomimetic drugs, sudden gain in weight tell you the thyroid problem is coming or the fluid overload is happening, and peripheral vascular disease, new onset of endocrine disease, when the patient develops malignancy and on chemotherapy, and of course, the last but not the least is COVID, which itself may precipitate an uncontrolled blood pressure in a patient who has got controlled blood pressure. So these are the reasons for a primarily well-controlled hypertension patient can suddenly go into an out of control hypertension. So having seen the etiology, now look at the age of the hypertension. So when you look at the age and hypertension, when the patient is young, majority of them are normotensives, and the most common cause of hypertension here once again is systolic and diastolic. You can have a small percentage of isolated systolic and a small percentage of isolated diastolic. But the age advances. In the middle age, the most common blood pressure here will be the systolic and diastolic hypertension as well as isolated systolic hypertension. But as the age advances, isolated systolic hypertension increases and isolated diastolic hypertension decreases. And as the age advances, there is a progressive decrease in normotensives. So this is how we understand the age and blood pressure. But the most common cause of hypertension in any age will be systolic and diastolic hypertension. In elderly, it will be isolated systolic hypertension. In the young, still it is systolic and diastolic hypertension, followed by systolic and isolated diastolic hypertension. So this is how we can understand the age and hypertension, what hypertension you expect in that particular age and how to deal about that. So to tell you about the importance of diagnosis of hypertension, whether it's a true hypertension or a pseudo hypertension in the elderly, we do what is known as Osler's maneuver. In many times, we diagnose pseudo hypertension in elderly, not because of increase in intraluminal blood pressure. It is because of the hardening of the arteries. So here, when you elevate the systolic pressure in the cuff and make sure the pulse is collapsed, and if the pulse is radial pulse and the brachial pulse is collapsed, you are not supposed to feel the pulse, feel the artery at all. So in spite of being pulseless, if you are able to feel the artery like a nerve or a cord, that means it is hardening of the wall of the artery, which produces pseudo hypertension. And this maneuver is called Osler's positive. Osler's positive is nothing but when the artery is pulseless, still you are feeling the artery, that is Osler's positive. When the artery is pulseless, you are not supposed to feel the artery. If the artery is felt when the artery is pulseless, this is Osler's positive, and this is going to be a pseudo hypertension. When Osler positive and the Osler negative, what is meant by Osler negative is pulseless artery is not felt. That is Osler's negative. So in this way, you have to rule out the pseudo hypertension. Then we diagnose hypertension by place, where the hypertension is. Not all hypertensions are in the clinic. There are many, many hypertensions. So today, the hypertension's diagnosis and management is not going to depend upon only clinic blood pressure measurements. That's a very, very important message. So you cannot just take one clinic blood pressure measurement and start treating the hypertension. So we must have a very important information by out of clinic blood pressure readings, either by home blood pressure monitoring or by ambulatory BP monitoring. So all the three should be there. your clinic blood pressure recording, the home blood pressure recording, and 24 hours recording. So with this, we can classify with this information whether it is the out of clinic blood pressure is high or clinic blood pressure is high. We can divide them into either sustained hypertension, where both out of clinic blood pressure as well as the clinic blood pressure is high. The opposite is normal blood pressure, where clinic blood pressure and out of clinic blood pressure is normal. Then you have two important hypertensions, which is wrongly diagnosed by clinic blood pressure alone. One is a white coat hypertension, where your clinic blood pressure is high, out of clinic blood pressure is normal. So it constitutes almost 25% of hypertensions we diagnose at clinic. So here, how to suspect white coat hypertension? For a long-standing hypertension, you may not have hypertension-mediated organ disease, and your clinic blood pressure is high, your home blood pressure or out of clinic blood pressure may be normal. The opposite thing is masked hypertension, whereas your clinic blood pressure is normal, but out of clinic blood pressure is high in the home or in the working place. I insist on in the working place, not only in the home, but in working place. So this is called the masked hypertension. 1 in 5 may have a masked hypertension. This is not diagnosed in clinic at all. So how should we, even if the pressure is normal clinic, how are you going to suspect masked hypertension? You are going to suspect masked hypertension by an unexplained hypertension-mediated organ disease. For example, a patient who consistently has normal blood pressure in clinic has got hypertensive retinopathy, or left ventricular hypertrophy, or albumin in the urine. So you must suspect a masked hypertension and try to get the information about out of clinic blood pressure. So these two blood pressures, white coat hypertension, masked hypertension, cannot be diagnosed in clinic. So you have to employ methods by which you can take the blood pressure out of clinic and then get these two blood pressures. Then, of course, we diagnose blood pressure by time. In which time of the day the blood pressure is high. So we divide the blood pressures, for example. So this is how the blood pressure, normal blood pressure for out of clinic blood pressure recordings. The clinic blood pressure of 140/90 is equal to home blood pressure reading of 135/85. That means anything above 135/85 in home blood pressure recording is hypertension. Daytime ambulatory BP monitoring will be 135/85. 24 hours average ambulatory BP monitoring is 130/80. And automated, I told you the automated office blood pressure is 135/85. Your nighttime blood pressure should be 120/80. So anything above these values in these blood pressures is considered hypertension, because this is equal to 140/90 blood pressure in the clinic. So that's why we have different blood pressures for blood pressure, the different thresholds for diagnosing hypertension regarding the place where the patient is. Now, the nighttime blood pressure is very, very important, because the nighttime blood pressure should be equal or less than 120/70 or 120/80. Some people say 120/80, some people say 170/70. So whenever it is equal or more than 120/80, then it is called nocturnal hypertension. So usually the blood pressure falls by 10 to 20% at night, which is called dipping. The normal patient should have this amount of dipping. If the dipping is between 10 to 20%, it is normal. If the dipping is between 0 to 10%, it's non-dipping. If the blood pressure increases in the night, it is reverse dipping. When the blood pressure is falling excessively in the night, it is extreme dipping. So the non-dipping or the reverse dipping are the ones which will supposed to have increase in organ damage or increase in hypertension mediated organ damage, and also they are going to have increase in cardiovascular event and mortality in spite of having identical daytime blood pressure. That's why it is not of importance is given to nighttime blood pressure. So if we want to divide the blood pressure throughout the day, daytime hypertension or morning hypertension is early morning hypertension is above 135/85 because it is estimated by either ambulatory BP monitoring or a home BP monitoring. Sorry. The clinic blood pressure should be less than 140/90. Daytime hypertension is once again more than, equal or more than 135/85. And the factors which are contributing to daytime hypertension are the work stress, home stress, exercise, and smoking. Once again, the average daytime blood pressure is estimated by ambulatory BP monitoring or home blood pressure monitoring. What is contributing to early morning surge is high salt intake, alcohol, smoking, cold temperature, and Asian ethnicity. And of course, we have this blood pressure, which is the most important blood pressure, because when you compare all this blood pressure, the pressure which gives you the future cardiovascular event risk is the nocturnal hypertension. It is going to be high salt intake, CKD, diabetes, sleep apnea, insomnia, once again, Asian ethnicity, which can be taken by only ambulatory BP monitoring. But now we have extended home BP monitoring, which can take some readings in the night so that we can have an idea about the nocturnal hypertension. So what is very important to realize is that a single clinical blood pressure reading is not enough. So here we diagnose hypertension according to the time of the day. It can be early morning surge, or it can be a BP at the high BP in the clinic, or it can be average daytime blood pressure may be increasing, or the nighttime blood pressure is increasing. Each one of them have got different etiologies, different pathogenesis, and each one of them may have different thresholds at which we diagnose hypertension, and each one of them will have different type of management. So that's why the diagnosis of blood pressure is also depend upon the time of blood pressure recording we do. So now we have a very interesting concept of nocturnal hypertension only. Patient may have a normal blood pressure in the daytime, but nighttime blood pressure alone can increase. So now this new entity is called isolated nocturnal hypertension, which can be only diagnosed by a home blood pressure recording, extended home blood pressure recording, or ambulatory BP recording. And one of the papers said this guideline 120 to 129, and of course 70 to 79, and the treatment target, they say the treatment target for nocturnal hypertension. So it's a very confusing field now. We do not know what is the target you are supposed to get when you start treating 120 and above in nocturnal hypertension, what the target you are supposed to get. So the exception to this rule are the patients who are above 65 years, chronic kidney disease, and is in these patients, the treatment target should be 130, 139, and 70 to 179, and not 120 to 139. So this is an emerging field, an isolated nocturnal hypertension. And what is, and we are already seeing this is the one which is the most important predictor of future cardiovascular risk. And there is huge research going on how to tackle and what is the threshold at which you have to start and what is the target you are supposed to get, because this is a double-edged weapon. So when you start treating the nocturnal hypertension only and get your extreme dipping, you will once again land up with the problem in the morning. So that is a developing field of nocturnal hypertension. Then we can diagnose hypertension by position. The position is very important. Sometimes the patients may have high blood pressure on standing. We had a postural hypotension. Most often we concentrate on postural hypotension, but many of us do not realize there is an entity called postural hypertension. So when patient stands, if the patient's systolic pressure increases by 20 millimeters of systolic, either by active standing or by passive standing. The passive standing is by hilt table and the active standing is patient is standing. So unlike postural hypotension, we do not have a diastolic number to diagnose postural hypertension. So the postural hypertension is very important because it may indicate a clue to your secondary hypertension. The most important secondary cause is being pheochromocytoma. And the postural hypertension tell you that is, there is an exaggerated compensatory mechanism which is working. Postural hypotension is the failure of autonomic nervous system working to restore the blood pressure, whereas postural hypertension is an exaggerated compensatory mechanism which goes out of control to produce more blood pressure. So that's why when you make the patient stand, it is not only the postural hypotension you have to look at, you have to also look at the postural hypotension, which may have a different mode of treatment and different type of approach. So sitting blood pressure, and so the other important and very difficult blood pressure to treat as far as the position is concerned, called supine hypertensive orthostatic hypotension syndrome, where on lying down the patient may have high blood pressure, on standing the patient may have low blood pressure. So it's a very, very difficult problem to treat, because if you treat supine hypertension, there will be exaggerated orthostatic hypotension. If you treat orthostatic hypotension, you will have exaggerated supine hypertension. So that's why it is most often happens in patients who have got a significant autonomic disturbances. It has got multiple etiologies, variable course and diverse outcomes, very difficult to treat. So we have got a lot of methods by asking the patient to elevate his head and also make him to stand with very, very with a long intervals in one posture to the other posture, and also use very cautiously the drugs you have to get. So it's a very, ultimately what you have to do in this situation is not to treat the hypertension and hypotension. You have to find out the basic cause of this autonomic problem, like Parkinsonism, or like autonomic diabetic autonomic nervous system disorder, or a primary autonomic system disorder. So unless you correct that, it is very difficult to treat only the hypertension where the patient is going to have in supine and also standing. So we can diagnose hypertension by the position also, lying down, sitting, and standing. So all the three things can have hypertension. Then we can diagnose hypertension by presentation, whether it is an acute presentation or a chronic presentation. So whenever the patient comes with an acute presentation with a BP of more than 180/120, it is called hypertensive crisis. Once you have a hypertensive crisis, at this point in time, you have only two things to see, whether it is hypertensive urgency or a hypertensive emergency. In a hypertensive emergency, the patient may walk into your clinic with slight headache or giddiness. When you take the blood pressure, it may be 200/120. This patient may not have a significant dyspnea, significant cardiovascular event, or a significant cerebrovascular event. So this is called urgency. Without acute end organ damage presentation, acute clinical presentation. Whereas for the same blood pressure, if the patient is going to come to you with acute pulmonary edema, or acute stroke, or acute kidney injury, or acute dissection, he comes under hypertensive emergency. So the hypertensive emergency patient should be admitted in ICU, and he has to be treated with parenteral antihypertensive drugs. And depending upon the emergency, you have to lower your blood pressure. Then we have various guidelines depending on what hypertensive emergency is. For example, it is ischemic, cerebrovascular ischemic hypertensive emergency. Blood pressure should be lowered very gradually. Whereas it is acute dissection, the blood pressure has to be lowered within 1 hour. So we cannot say with what time you have to lower the blood pressure in emergency. It all depends upon what condition the patient is going to have. Of course, in hypertensive urgency, you have to admit the patient. We always prefer the patient to be in the hospital for first 1 or 2 days and estimate the causes of hypertension and try to give him the oral drugs with a short-acting formula like clonidine, or the nifedipine, long-acting nifedipine, or the clonidine, or even labetalol. These are the 3 important drugs which are prescribed for hypertension, which are quick-acting, and try to get the blood pressure around 24 hours. So around 24 hours. Why we want this patient to be getting admitted is that at any point in time, an urgency patient may transform into an emergency patient. That's why it is preferable that the patient should be in the hospital. Of course, the previously we used to call them as malignant hypertension and accelerated hypertension, primarily depending upon the eye changes. So accelerated hypertension is the one which has got the papilledema, which comes under hypertensive urgency. And of course, the patient has got other forms of retinal involvement. It may come under hypertensive urgency. And of course, usually this type of malignant hypertension will be associated with the greater diastolic pressure of more than 130. So this is the acute presentation. Of course, we have already seen the chronic presentation. So the diagnosed hypertension also depend upon whether the patient is coming to you with acute hypertension or a very severe hypertension with or without a clinical damage or a clinical presentation on cardiac side, brain side, kidney side, or on the vascular side. Then we can diagnose hypertension by control, whether BP is controlled or not. So that's why we call a patient as having a difficult to control hypertension when you are using 2 to 3 drugs, not specifically a particular drug. When you are using 2 to 3 drugs and the BP is not a target, then he comes under what is known as uncontrolled hypertension. Once the patient has got uncontrolled hypertension, you make sure you are putting 3 drugs, which must include a diuretic. So at optimal doses, 3 drugs, including a diuretic at optimal doses. Then the BP is not a target. These are all 2 weeks intervals. This BP at all are 2 weeks intervals. So the BP is not a target after using 3 drugs and with a diuretic in the optimal doses. Then the patient comes under apparent resistant hypertension. Once there is apparent resistant hypertension, you have to rule out a lot of pseudo-resistant causes. The pseudo-resistant causes can be a white coat hypertension, improper method of recording hypertension, physician's inertia, pseudo-hypertension of the elderly, or the patient's related factors like drug patient's compliance, adherence, drug factors like the abnormal dosing of the drugs, abnormal combination of the drugs, or abnormal timing of the drugs. When you rule out all this, the patient comes under true resistant hypertension. The true resistant hypertension can be uncontrolled true resistant or controlled resistant. If the patient is using 3 drugs and the patient is not under control, then it is a true resistant hypertension. When the patient has got controlled blood pressure with 4 drugs, it is controlled resistant hypertension. Then of course, beyond that, if still the BP is not getting controlled, you add the 4th drug and 5th drug, and the BP is not at gut with 5 drugs or more, then it becomes a refractory hypertension. So now you can diagnose different types of hypertension according to control. It can be an uncontrolled hypertension, very non-specific, because you are using 3 drugs of your choice. Then you optimize 3 drugs with a diuretic, it becomes apparent resistant. Then you rule out pseudo-resistant causes. Then it becomes either controlled resistant or uncontrolled resistant. Then even then it is not controlled, use 5 drugs or more, then it becomes refractory hypertension. So this is the diagnosis of hypertension by the control. When it is not controlled, how you diagnose other steps or the other forms of hypertension. So when you look at the real world data, 1 in 5 may have true resistant hypertension. This is what I mean, true resistant hypertension. In this true resistant hypertension, majority of them will be using 4 drugs with a normal blood pressure. They come under controlled resistant hypertension, 2/3 of them. 1/3 of them will have uncontrolled resistant hypertension where there are 3 drugs and they are not getting controlled. And a very small percentage of them may go in for a refractory hypertension. So this is a diagnosis by the numbers. Then of course they can diagnose hypertension by the prognosis. Which hypertension is going to have a best prognosis? Which hypertension is going to have a bad prognosis? So when you look at the hierarchy of the danger of hypertension, the most dangerous hypertension will be hypertensive crisis, where the patient presents hypertensive emergency or an urgency. Then in a chronic hypertension, high systolic and low diastolic pressure is the most dangerous one because high systolic pressure will increase myocardial oxygen demand. Low diastolic pressure will decrease coronary blood supply. So there is a gross disparity between the demand and supply, which will produce further complications. Then comes isolated systolic hypertension. Then comes systolic and diastolic hypertension. And the best prognosis will be there for isolated diastolic hypertension, which is more common in the young. So here you can diagnose hypertension according to the prognosis. So you can diagnose whether this hypertension is going to have a good prognosis or a bad prognosis or a medium prognosis, depending upon whether it's a hypertensive crisis and what type of hypertension it is. So having diagnosed hypertension in 10 waves, then we come to the screening of hypertension. How to screen for a patient with high blood pressure or a normal blood pressure, I must say. So why the screening is important? For example, in the presence of what is perceived as normal persons, some of them may have hypertension. So if you pick them, the patients who got apparently normal people who got hypertension and pick them and do further tests, investigations and start treatment, you will definitely prevent future complications of hypertension. That is a basis of screening hypertension. So now it is a very important paper which is published in JAMA 2021, which is the latest recommendations for screening for hypertension in adults by US Preventive Services Task Force recommendation. So all these recommendations are grade A. To whom this recommendation apply will be adults of 18 years or older without known hypertension. That means any person, any adult of 18 years or older should be screened for hypertension. And of course, how to implement this hypertension? Screen all of them, measure this with a first office blood pressure or clinic blood pressure measurement. If the clinic blood pressure recording is high, before starting treatment, the important change in 2015 guideline is you have to confirm with out of clinic blood pressure recording. If the patient has got high blood pressure in clinic, you have to confirm it by out of clinical blood pressure recording, by which we mean you have to rule out white coat hypertension, or the BP is normal, then you have to rule out masked hypertension. So the blood pressure measurement should be taken at the brachial artery with a validated, accurate device in seating position. We already told you how to record the blood pressure. So this is how to implement the recommendation in patients at 18 years or older. Then the question comes, when the patient has got a normal blood pressure, how often you must screen? If the patient has got the hypertension and the patient is above, screening of hypertension should be done, even though the patient has got normal tension. If the patient is 40 years or older, every year, the screening should be done in every year of 40 years or older, even though they are normotensives. And also patients with the high normal blood pressure, overweight, obese, and black patients. Screening can be less frequently, above every 3 years, in those patients who have got between 18 to 39 years, who are not at increased risk of hypertension and with a normal previous blood pressure recording. Then this recommendation has come out the rationale of why we have to screen hypertension in 18 years. The rationale is the initial one-time recording of the office blood pressure has got adequate specificity but a low sensitivity for detecting hypertension. So this force found adequate evidence that initial positive screening result can be confirmed by out of clinical blood pressure recording, by home BP recording or ambulatory BP recording. So that's why you detect hypertension. What is the benefit of early detection and intervention treatment? So there is a strong evidence that the treatment of hypertension in adults at this stage will substantially reduce incidence of cardiovascular events. So you treat the patient at the earliest, then you can prevent hypertensive complications. Is there any harm of detecting hypertension at this age of 18 or 20? There is no harm at all. Very few major harms. So what will be the net benefit? The net benefit is positive. That means using a reaffirmation of deliberation process, the US task force concludes high certainty that screening of hypertension adults of 18 years or older has substantial net benefit. So that is about the screening, a very clear guideline on screening of patients with adults on 18 years or older. And once you have high blood pressure in the clinic, what you must do and how to implement. And when the patient has got a normal blood pressure, how often you have to screen for that patient for the presence or the absence of hypertension. With this, I'll end my talk by quoting this. This is one of the old quotes. The only way to escape from hypertensive complications is dying early. If you die early, you will not develop hypertensive complications. Then, of course, but the newer quote will be, the only way to escape from hypertensive complications is the earliest diagnosed hypertension and adequate and scientific management of that hypertension. You can escape hypertensive complications without dying. You can definitely prevent complications. For that, I think the diagnosis of hypertension talk, which I gave you, may be very useful. I hope this will be useful. Thank you for your patience.
Thank you so much. Thank you so much, Chenipan, for that excellent presentation on diagnosis. I think most of the audience would have been feeling happy because first time they would have said they would have listened to such a diagnosis on 10 different topics, different titles. Chenipan, before I go to Manisha, we'll play the Kahoot and then I'll come back to you and Manisha for questions. I hope all of you have downloaded the Kahoot app. Those of you who have joined the first time, I already told you how to download the Kahoot app. And once you download the Kahoot app, we'll give a game pin number. And by putting that game pin number, you can play the game. And as I told you, just participate. Don't worry whether you get marks or don't get negative marks, no problem. I'm not going to announce who has got how many. Only I'll announce 1 to 5 marks, 1 to 5 stand. I'll give the game pin now. I hope all of you have got this. 484-3229. The game pin number is 484-3229. You can also take a photograph of the scan with the mobile phone, and you can play. Now there's a nice this one. So 484-3229 plus this. As usual, all my good battalion has joined, right from Gary, Karthi, Ramesh, Anandanagar, Mitchell, Suresh, Abhinaya. I'm very, very happy and pleased. Whenever and wherever we do any program, your support is so good. So I hope the newcomers also will join and play. As I told you, every question 20 seconds, and those who answer even 5 seconds or 4 seconds, they get more marks.
Sir, kindly unmute, sir, unmute.
Even people who are, in the Facebook, they can also join Kahoot by scanning that code. So I'll give another 3 seconds for everybody to join. I was welcoming Anil Virmani also, who has joined late. There are 2 Meganadans, I see. Fine. So I'll give you last 2 seconds. As I told you, if you join Kahoot, you will be happy to participate. One. Number two, we have got the records of people who are joining. So for these people who attend 5 webinars with 5 Kahoot, we will send them the home BP monitor, home BP monitor. Those who join all the 5 webinars, they'll get a certificate from the World Lung Foundation, also from the Tamil Nadu Medical Council credit points. Okay, last 1 second. I think we'll start now. Already 80 people have joined. So, ready? I'll start now. The diagnosis of hypertension, accurate BP measurement. 3, 2, 1. The first question. The correct BP measurement technique includes all except empty bladder, legs not grounded, no talking, correct cuff length. Correct BP measurement techniques includes all except. Super. 42 persons have answered correctly. Now we'll go to the second question. Except legs not grounded. Legs should be grounded. Okay. Now the scoreboard. Abhinaya first, Anand Nair, Rajesh. Now the second question. The BP column should be lowered at the speed of dash seconds. 1.2 to 3 seconds, 2.3 to 4 seconds, 3.4 to 5 seconds, 5 millimeter, 4.5 to 6 millimeter. The BP column should be lowered at the speed of A, B, C, D, whichever is correct. Yes, it should be lowered at the speed of 1.2 to 3 millimeter.
Sir, it is not 1.2. The number is first answer.
Sorry, yeah, correct.
2 to 3 millimeters.
Yeah, 2 to 3. Sorry, 2 to 3. So I think we'll go to the scoreboard. Abhinaya, Anand Nair, and Akhil. Now, the third question: where you use large cup for a small arm, the systolic blood pressure is increased, systolic blood pressure is decreased, diastolic blood pressure is increased, and diastolic blood pressure is decreased. If you use large cup for a small arm, systolic blood pressure is decreased. When you use large cup for a small arm, systolic blood pressure is decreased. We'll see who are the now Anand Nair, Abhinaya second, and Mandy. Now the fourth question. Patient has blood pressure of 160 by 100 with LVH. Serial readings are necessary to diagnose hypertension. Is it the statement is yes or no? If somebody has got BP of 160 or 110, do you require serial readings, especially with LVH? Yes or no? Very simple. I think all should be right. No. 55 people have answered. Let's see who are the, again, Anand Nair, Abhinaya, Saravanan. Now, hypertension by ISH guideline is more than 130/80, more than 140/90, more than 150/90, NOA.
None of the above.
None of the above. More than 140/90. Abhinaya again succeeded Anand Nair, Subra Bandari. 6th question, hypertension in young, which BP is common? Isolated systolic, isolated diastolic, systolic and diastolic, high systolic and low diastolic. Systolic and diastolic. Though Tenipan said isolated diastolic is common in young, it is not more common like systolic and diastolic. Tenipan?
Yes, sir. Yes, sir.
Yeah. Okay.
At young age and middle age, systolic and diastolic is more common. In later age, it will be isolated systolic is more common.
Compared to that, isolated diastolic is more common in younger people.
Exactly. It will come down as the age advances.
Okay. Kumar, Ranjit, Abhinaya. Now, Seventh question. The common secondary causes include all except drugs, hyperparathyroidism, OSA, obstructive sleep apnea.
Remember, drop it.
Super.
Yes.
Except hyperparathyroidism, correct. Now we will go to the score. Ranjit, Abhinaya, Kumar. Eighth question. Nocturnal hypertension is a form of secondary hypertension, masked hypertension, primary hypertension, either one of the above. Nocturnal hypertension is a form of masked hypertension.
Excellent, excellent. Okay.
Now, Anand Nair, Kumar, Subrata Bandar. Which BP has got best prognosis? Isolated systolic, isolated diastolic, systolic and diastolic, high systolic, low diastolic. Best prognosis, not bad prognosis, best prognosis. Senipan has mentioned about this. Yes, isolated diastolic is best prognosis. High systolic and low diastolic is worst prognosis. Senipan?
Yes, sir. Yes, sir.
Anand Nair, Subrata Bandar, hit 2. Now the 10th question. Which is refractory hypertension? BP not a target with 3 drugs, BP not target at 4 drugs, BP not target with 5 drugs, BP not target with 6 drugs. Which is refractory hypertension? Even with X number of drugs, refractory hypertension not at target. Yes, very good. 36. With more than 5 drugs, even if the BP is not controlled with 5 drugs, it is called refractory hypertension. Subhata, Hitu, Anand Nair. Then Osler negative. Is it true hypertension or pseudo hypertension? Osler negative is a tricky question. Osler positive, Osler negative. This is Osler negative. Is it true hypertension or pseudo hypertension? Yes. Osler negative, but the person has blood pressure, but Osler negative, then it becomes true negative, true hypertension.
Osler negative means you are not following the pulseless artery. That is true hypertension. Osler positive means you are feeling the pulseless artery, means the artery wall is thickened. So it is pseudo hypertension.
Okay. Now Anand Nair, Subrata Bandar, and Hitu. The last question of the day, what is the age at which screening should begin? It is 20 years or 18 years, 22 years and 25. Because it's a very important question in the public health. Super. 64 people have answered. That means you are all ready for screening. Our purpose of this webinar is to make you to do screen more and create more awareness. That is the purpose of this webinar. I think more than 90% have answered correctly, so I'm very happy. So now we'll see who is number 1. Abhinaya is 9 out of 12, and then 10 out of 12 Subrata Bandar, and 10 out of 12 again by Anand Nair. I congratulate all the participants. Kumar and Gabra is runner. Now I'll stop sharing. I'll go to Manisha.
Yes, sir. Please tell.
Yeah,
yes.
Manisha, you heard Dr. Chenipan
Yes.
explaining about various parts of diagnosis. Now, as a nephrologist, your angle of diagnosis of hypertension and kidney and diagnosis, please.
So first of all, sir, I would like to congratulate Dr. Chenipan. He has covered hypertension from A to Z, everything, even from the point of view of nephrologist, cardiologist, physician, endocrinologist, everything. So my views on hypertension do not differ from Dr. Chenniyappan's views. He has given a very clear-cut picture. So first message I would like to give to all the listeners, what Dr. Chenniyappan already said, I would like to reiterate that please measure the blood pressure first. It's not that we start measuring only in elderly. Sir said about the age of 18, he has given guidelines. And in fact, I'm a pediatrician as well before I became a nephrologist. So it's taught that after the age of 3 years itself, blood pressure should be measured. So that's the most important thing. We can talk volumes about hypertension, but if you don't check the blood pressure, it all goes waste. The second important thing is, good, you have started measuring the blood pressure, do it in a proper way. I will not repeat what Dr. Chenniyappan has said. He has shown step by step in a very nice manner, in very simple manner. We should follow all the steps of measurement of blood pressure. Then the third thing, what Dr. Muruganathan asked, as a nephrologist. So as a nephrologist, it saddens me to see that what happens is hypertension in the young age, severe hypertension, hypertension with asymmetrical pulses, hypertension with a renal bruit there, hypertension with severe end organ damage, hypertension with protein in urine. It's just treated with some BP drugs and no other investigations are done. We often miss secondary hypertension. Hypokalemia with hypertension, we do not bother to check for the cause. So most of the times hypertension is diagnosed and treatment is started. And what happens is the patient walks into a nephrology clinic after 5 years of being hypertensive with end-stage kidney disease, which he has to live with for rest of his life. He has to go on dialysis, transplant. For the simple mistake, what was done was when the blood pressure was diagnosed with all these features, we simply forgot about secondary hypertension, missed it completely when there was a window of opportunity to treat that hypertension. So my sincere request, Dr. Chenniyappan already said, any hypertension in the young, first point. Second thing is severe, difficult to control hypertension. Third point, asymmetry of pulses. Fourth point, renal bruit. Fifth point, hypertension with pulmonary edema. Hypertension with hypokalemia. These are some important things. In addition, if you have sudden worsening of renal function, sudden rising of hypertension after starting certain drugs, ACE inhibitors, you may be having a case of renovascular hypertension. And Dr. Chenniyappan also said, always go through the drug history, especially the females, the oral contraceptive pills, steroids, NSAIDs are an important cause of hypertension. So never ever miss secondary hypertension because that's the one which is treatable. And I mean, you can save so many cases of chronic kidney disease, end-stage kidney disease from happening. So that's the next message. And I think OSA, often we forget about sleep apnea. That's an important cause of hypertension. So these are, in a nutshell, the very important causes we should not miss. Out of secondary hypertension, 90% is renal hypertension and remaining is endocrine hypertension. And a very small segment is genetic hypertension. So genetic hypertension, Dr. Chenniyappan has not covered. Genetic hypertension is because of abnormality of renal transporters. And the important thing is it occurs in very young. It's generally autosomal dominant and there is often a family history. So you have a hypertension with onset below 20 years and you have CVA in the family. Please keep in mind genetic hypertension, the important ones being Little syndrome, apparent mineralocorticoid excess syndrome, glucocorticoid remediable hypertension, so on and so forth. So these are the hypertensions, Gordon syndrome. So these are the hypertensions where you need to give a specific treatment. So I think these are important secondary hypertensions we should never miss. And hypertension in the elderly age, you exclude everything else and then you label it as essential hypertension. Regarding the treatment, sir has beautifully covered how it needs to be treated. Most important thing in India, what I feel is apart from drug management, restriction of salt is very, very important. We Indians take around 2 teaspoons salts per day, 10 gram, and we need to restrict it to 5 sodium chloride or 2.3 gram of sodium. And the best important thing in a patient who seems to be resistant to hypertension, please check the 24 hours urine sodium. It should be less than 100 milliequivalents per day if the patient is on a sodium restricted diet. Sir has already explained beautifully about masked hypertension, about the white coat hypertension. These things are also important. So I guess this is what I would like to add. In fact, sir has covered everything. And if there are any specific questions, I would be happy to answer. Thank you, Muruganathan sir, for the great opportunity.
Thank you. Thank you, madam.
Kindly unmute, sir. Unmute, sir.
Okay. See, Manisha, having mentioned Liddle syndrome and Gordon syndrome, what is the difference between Liddle syndrome and Gordon syndrome?
So, sir, Liddle syndrome is overactivity of the epithelial sodium channel in the collecting duct. It's a gain of function mutation. So what happens is here, the hypertension starts in young. It's autosomal dominant variety of hypertension, and aldosterone is suppressed. It's low. So that's important. Gordon syndrome is because of mutation in the distal tubule. So distal tubule, and here the hypertension generally, you also call this PH, it's also known as PHA2, pseudo hypoaldosteronism type 2. And here again, you have hyperkalemia. So remember, hyperkalemia with hypertension, one of the important causes is renal failure. Other important causes, Gordon syndrome. Whereas in Liddle, you have hypertension with hypokalemia and low levels of aldosterone. So it's, people may generally not encounter genetic hypertension. It's not that common. I just wanted to make the point that if you are dealing with young hypertensives with a strong family history and CVA, etc., below the age of say 20 years, 30, 15 years, please keep in mind this genetic syndromes of hypertension as well. So Gordon is hyperkalemia with hypertension, whereas Liddle's is hypokalemia with hypertension. And the treatment of Liddle syndrome, remember, is you have to give amiloride. Nothing else works here. And Gordon syndrome, thiazide diuretics are very effective because Gordon syndrome has manifestations which are just opposite of manifestations when the patient is on thiazide diuretic. So thiazides cause hypotension, hypokalemia. Gordon causes hyperkalemia with hypertension. So obviously, logically, the treatment of Gordon syndrome is thiazide diuretics. Liddle syndrome, the treatment is amiloride, which is an ENaC channel blocker.
Yeah, Manisha, I purposely asked this question because we did not cover genetic hypertension. So that's why we want to brought out these points. Tell me, is amiloride available as a single drug, as a mono drug, without combination in India, Manisha, amiloride?
Sir, it is available, but your question is very pertinent. Most of the times it's available in the form of combinations. So
Yes.
sometimes we end up using the combination because it doesn't cause harm and we need the amiloride part of it because Liddle syndrome, remember that the only drug which works is a ENaC channel blocker because Liddle is a gain of function mutation of the ENaC channel. ENaC channel means epithelial sodium channel in the collecting duct. So if you use spironolactone or anything else, it doesn't work. You have to use amiloride or even preparations containing amiloride for that matter.
Okay, actually, today we are not covering any management of hypertension, but still because you are there, I thought we'll get an expert opinion from you. One more
Absolutely.
question. One more question from for you before I go to Chennaipan about postprandial hypotension. What is isolated diastolic hypertension in young, and what is sudden isolated diastolic pressure in young, older people? What is the cause of the diastolic
So
pressure?
I didn't get your question. So you are asking about isolated
diastolic in young people. What is the pathogenesis? And what is the pathogenesis of diastolic blood pressure after 65 years when somebody has got renovascular and all that? So Chenipan was mentioning diastolic hypertension in the older people. Suddenly, if they get, you must think about secondary hypertension.
So in the renal patients, generally we get both either combined systolic and diastolic hypertension, or more often in elderly, we get isolated systolic hypertension. The pathogenesis of diastolic hypertension in renal patients is unclear. So it's not very clear what the cause of that is, but it's very uncommonly encountered. So I think Dr. Chennaipan's experience with diastolic hypertension
No, actually,
must be much more than mine, because in renal patients, we do not encounter that sort of hypertension frequently. It's either a combination of systolic, diastolic, or isolated systolic.
No, actually, Manisha, when somebody has got hypertension, after 65 years, suddenly only diastolic is more in older people, it means it's renovascular. So that's why I thought
Now,
I will ask.
renovascular generally in elderly, what we see is a combination of both systolic as well as diastolic, sir. In our clinical practice, though the theory mentions that these people, like renovascular people, might have more of diastolic, but that's not what we see in clinical practice, sir. We see a combination of both systolic as well as diastolic hypertension in the Indian scenario.
It's a clue how to diagnose secondary hypertension. If somebody above 65 years got diastolic hypertension, because diastolic hypertension is common in young people, not older people. If somebody has got a diastolic hypertension above 65, think of secondary hypertension. That is the clue. That is the history.
Yeah, that statement has been mentioned in books that, I mean, in case isolated systolic hypertension occurs with age, but in case you have more prominent diastolic hypertension, look for secondary causes. This is what is said.
Yeah,
but renovascular hypertension, we see both, sir. I mean, systolic is there and they also have diastolic hypertension. So combination of both generally we see.
Okay, thanks, Manita. I will come back to you. Chenipan, your first question on postprandial hypotension and postprandial. What is postprandial hypotension? Which one?
So I think we are talking about diagnosis of hypertension, sir.
Okay.
We'll leave that to the hypotension. So postprandial hypotension is primarily due to, just like postal hypotension. In a postal hypotension, when the patient stands, the sympathetic system is not working to compensate for the peripheral pooling in the legs. Postprandial hypotension is the failure of the sympathetic system to compensate for the pooling of the blood in the splanchnic circulation. When the blood goes into the gut for the digestion, then naturally the sympathetic system has to come in to make sure that the cardiac output is not falling. So the difference is, it is the failure of the sympathetic system to compensate wherever the pooling is happening excessively. In postal hypotension, the pooling is happening in the legs. In postprandial state, the pooling is happening in the gut. So that gut reduction of the preload. So naturally, both of them will reduce the preload. When the preload is decreased, cardiac output is decreased, you have hypotension. So there's a failure of the sympathetic system to come in to compensate for that. So the postprandial hypotension is very common in patients with the diabetes, especially with autonomic nervous system disorders. So many times you have seen some of the patients will say, after I take blood, after I take the tablets and the food in the morning, I have to immediately sleep. I feel so drowsy. It's a very common complaint of many patients who are taking antihypertensive drugs. These are the patients should be screened for postprandial hypotension.
Yeah, and also
so the postprandial hypotension should be screened after the patient takes food up to 30 minutes. Any 5 to 10 minutes interval, up to 30 minutes, the blood pressure has to be seen.
Chenipan, sorry, because you yourself taught us, it should be even after 2 hours also postprandial hypotension, even if it is 10 millimeter less, below 90, it is again postprandial hypotension. This is what
that's all.
So
minimum of 30 minutes or maximum 2 hours.
Yeah, and also even 10 millimeters less than 90. I mean, it comes to 90 also. Normally 20 milli, but even if it is below 90 after food, after 2 hours, if somebody
that's two criteria, sir. One is the absolute fall, and second is the absolute number.
Yes. Okay, because you have covered all the hypertension. So I thought postprandial hypotension also we can bring it, because that is your favorite slide. What you show, but today that slide is not there, so I thought I'll ask that question. Okay, fine. Another question to Manisha. Manisha, what about intradialysis pressures? It is hypotension or hypertension. Is there any target or any value before, I mean, by which you can calculate whether a patient has got hypotension or hypertension during dialysis or intradialysis?
So, sir, thanks for that question. So, dialysis patients during dialysis are prone to both hypotension as well as hypertension. Often we think during dialysis there is removal of salt and fluid, so patient will have tendency to hypotension. So, generally hypotension is more common. If you put so much of ultrafiltration quickly, hypotension may be common. If the patient has meals before going for dialysis, the blood gets diverted to the GI system, and again you have hypotension during dialysis. And if you are doing dialysate with a relatively warm dialysate, You may have hypotension during dialysis. Some patients, they take the blood pressure drugs just before coming to dialysis, and again, they may have hypotension. Another important cause in diabetic patients is again autonomic neuropathy, and sometimes cardiomyopathy as well, where you can have hypotension. Again, blood loss during dialysis may cause hypotension during dialysis. So these causes are quite apparent and logical, and anybody can make these out. Now, people wonder why hypertension occurs on dialysis. So again, many of the antihypertensive medications, they get dialyzed during the process of dialysis. So that becomes a problem. That is one of the causes of hypertension on dialysis. Other thing is, if you remove the ultrafiltration quickly and you cause stimulation of the renin-angiotensin system, and what happens is the body tries to compensate. There is sympathetic overactivity, there is release of renin, and that may sometimes contribute to hypertension on dialysis. So both hypo and hypertension can occur. One important message is many of the physicians would be seeing these patients on dialysis. So remember that the blood pressure on dialysis should be seen during dialysis for adjustment of fluid shifts and ultrafiltration rates during dialysis. But for the management of blood pressure and usage of drugs and dose adjustment of antihypertensive drugs, always check the blood pressure on non-dialysis day. Check the blood pressure on the non-fistula arm. So these are important things, and always titrate the BP medicines according to the blood pressure seen on non-dialysis days. Yeah. Those patients who go into repeated hypotension on dialysis, then we tell them not to have food before dialysis. We tell them to avoid taking the BP drugs on the day of dialysis. They can take them later on. We tell them to avoid eating during dialysis. And in addition, sometimes we cool the dialysate when we are taking the patient for dialysis. So hypotension and hypertension on dialysis is a different entity, and I've tried to explain in a nutshell, because some of the dialysis patients would be managed by the physicians as well. Thank you.
Yeah, that's why this is a peculiar situation during dialysis. And one more important message I think from you I want is, in the post-dialysis or inter-dialysis stage, that is when you don't have dialysis, the best way to diagnose hypertension or hypotension is home blood pressure monitoring. What is your opinion?
You want the role of home blood pressure monitoring, sir?
Yes.
Yeah, so that's good, sir. That's good. So ABPM has come up in a big way. Both home blood pressure monitoring as well as the ambulatory blood pressure monitoring, both have come up in a big way, because in dialysis, during dialysis, the pressure what we take is not reflective of the patient's blood pressure. So we instruct the patient to take the blood pressure at home. We ask them to take twice a day at home. And in case they have facility for ABPM and the hypertension is difficult to control, in those cases, we take them up for ambulatory blood pressure monitoring as well. So home blood pressure monitoring is very important in CKD non-dialysis patients to pick up the white coat hypertension, mass hypertension. That around 30% of patients we see have these varieties of hypertension, and they also are associated with poor prognosis. It's not that they are benign. So white coat hypertension and mass both are important. In addition, in dialysis patients, we tell them to take home blood pressure with the blood pressure apparatus at home, morning and evening twice. And in case we have a doubt and the hypertension is not controlled, we use ABPM as well to find out whether there is a nocturnal dipping there or it's absent. So that also is important. ABPM is used in dialysis patients, CKD patients, as well as post-transplant as well. Yeah. And the role is coming up even in pregnancy-induced hypertension, ABPM.
Yeah. Okay. Now you have raised the point about pregnancy. Chennappan, what about the target threshold in pregnancy, Chennappan? Blood pressure in pregnancy.
So the pregnancy-induced hypertension, or now it's called gestational hypertension. And once again, the readings are very important. The timing is important. So anything, so the timing is between before or after 20 weeks. If it is before 20 weeks, it may be a chronic hypertension, or after 20 weeks, the first time hypertension can be of a gestational hypertension. So that the threshold to start the drug will be 140/90. Of course, the drugs, this is a very labile situation, especially during the term. Even the patients may have a normal blood pressure till that time, suddenly develop a hypertension and a proteinuria. So we've seen patients, suddenly the preeclampsia is developing. at the last week or the last trimester of pregnancy. So the threshold to start the drugs will be 140/90. And the drugs are labetalol is the first drug, and second drug will be nifedipine long acting. And then of course, we have methyl-dopa, hydralazine, and so on. So this 140/90 is the target, is the threshold at which you have to start the drug.
Chenipan, again, you are always talking about so many positions. What is the best position to diagnose hypertension in a pregnant woman? Sitting, lying, left lateral, right lateral?
Best position will be sitting itself.
Okay.
So best position will be sitting itself. That is the best position. So if at all you are taking the blood pressure in lying, it should be in the left lateral position.
Okay, fine. And your favorite question now, what is mask effect and weight coat effect?
So first time you are diagnosing hypertension, and the hypertension is high in clinic and normal in home, it is white coat hypertension. And if it is normal in clinic and high at outplace, it is masked hypertension. When you are treating hypertension and on drug, patient is on drugs, still your clinic blood pressure is higher than the home blood pressure, it is white coat effect. You are treating hypertension, still your home blood pressure is higher than the clinic blood pressure, it is masked effect.
Okay, because that was the one thing which I think we will have to highlight. Now, I think before, I mean, this is all my questions. Now I go to the chat box. There are so many comments only. It's only say excellent, excellent. Okay, Kahoot game. Just go slow, little more, little up. Yeah. Which limb is preferred for checking blood pressure? Right upper arm, left upper arm. And one more imaginary question: if the patient has no arm, what do you do?
Yeah, the first time when you check the blood pressure, it has to be checked in both arms. Okay. So first time the patient is coming, you have to check in both arms. Normally when you check the blood pressure in different times, that is you're not simultaneously checking. You are the single person who is checking in the right arm and left arm. The difference should be more than 10 millimeters systolic. If it is more than 10 millimeters systolic between the two arms, you have to suspect an arterial disease in a particular arm, and you have to take the blood pressure in which limb there is a high blood pressure is taken as blood pressure of that particular patient. If the patient does not have an arm, then of course the only method by which we can record the blood pressure, especially they said it's an accident, then of course the very important thing is to put an intra-arterial line to get the intra-arterial blood pressure. So that is the only way we can, when both arms are not there or significantly damaged, the intra-arterial recording is the only way we can get the blood pressure.
What about the lower arm pressure? Any reading difference? Any difference in the diagnosis?
Nowadays, the lower arm blood pressure is not given importance as the diagnosis part. So the lower arm blood pressure, the lesson method is to not to tie the cuff and take the blood pressure. You have to take from the posterior tibial artery to the Doppler. So that is the way to record the blood pressure in the lower limb today. Yeah. So if the important thing is to check the pulse in the lower limbs. If your pulse is well felt and there is no significant the brachiofemoral delay, that means it is not routinely the lower limb blood pressure is taken. So if at all you want to take, it is not tying the thigh cuff and taking the blood pressure in the popliteal artery. It is taken by the Doppler in the posterior tibial artery.
Manisha, is there any marker to find out whether they have got renal hypertension? Manisha? Manisha, are you there?
So the one more important thing about when we suspect renal hypertension and controlled hypertension, yes, is unexplained normocytic normochromic anemia. Yes. So we keep checking, see every 6 months or so the anemia, so or the hemoglobin and the CBC. When the patient has got unexplained NNC, we have found that's a occult renal class. So that's a very simple method of suspecting associated CKD, which is superimposed on a patient who's got already an essential hypertension which is controlled. So a very simple test, but the normocytic normochromic anemia. So
in other situation, the anemia will be different, is it? What is the significance?
The commonest anemia will be iron deficiency. Yes. So that is a common anemia we see. Okay. But the normocytic normochromic anemia is very peculiar to CKD. because of the decreased production of erythropoietin and so on. So it is actually normocytic normochromic. That type of anemia is one of the indicators of renal disease.
Manisha, are you there? Manisha? Manisha?
I think she left, sir.
Yeah, I think our internet is not working. I can hear her voice, but it's not very okay. Okay, there are a lot of encomium, Jennifer, a lot of people have appreciated the excellent talk, lovely, so and so and so. The recording is available.
I have not answered the limb of recording.
Okay.
So the limb of recording will be which hand the patient uses. If the patient is a right-handed individual, take the blood pressure in the right arm. If the patient is a left-handed individual, take the blood pressure in the left arm.
Okay, fine. So excellent presentation. Thanks to all, fantastic session. Which will be okay. I think we'll stop with this. We'll go to the Manisha. Manisha? No, I think okay.
That Sangaram can.
Yeah. Manisha is not there. Sangram, your final comment. Your final comment. We'll close. You tell me your final comment, Sangram.
As usual, it was an excellent session by Dr. Chennappan sir. My take-home message is only to record the blood pressure properly, follow the basic things like recording the blood pressure in sitting position, use the cuff measurement should be proper, blood pressure recording in the right upper limb, supine standing position, all those basic things to be taken care. That's all. Rest all the things has been discussed.
Yes, Chennappan, your final comment, Chennappan.
So I think the most important thing is to diagnose hypertension correctly. So of all things, I did the 10 things about diagnosis. The most important thing is the first one. Use the correct methodology, correct. I told you the 5 things, 5 rights. You just follow the 5 steps. That's the first crucial point to diagnose hypertension. Once you diagnose hypertension, then of course we have a lot of things to do, to look at the numbers, look at the secondary causes, then you look at the things, so many things. But the most crucial thing is record blood pressure by yourself and record blood pressure correctly. With patient preparation should be right, the cuff preparation should be right, the equipment preparation should be right, your performance should be right, and of course the important thing is to get the blood pressure numbers correct. So for that, you have to have the correct apparatus, correct patient's preparation, correct position of the patient, correct apparatus, and your ears and your methodology or performance, your performance. All that, I think in the entire talk, that is the most important aspect of the diagnosis.
Thank you so much, Chennappan, because accurate measurement, now every guideline, mentions at least 4 to 5 pages about accurate measurement. And one important, thing all of us should also understand and agree, clinical history and clinical examination, whether it is 2022 or 1985, clinical examination and the clinical history taking. And Chennappan has shown how to suspect secondary hypertension by only clinical history. And Chennappan has got always the favorite, history taking in the modern days. That also you should remember when you diagnose. Of course, the basic investigations we have not touched. The basic investigations for hypertension, already all of you know. So these are the basic investigations to diagnose hypertension. And LVH is also now a marker, they say, to find out the risk, especially in the 2022, there is a paper like that. So there are so many things now about diagnosing hypertension. We have covered all the points, and this is available in the link. I will send you the link. And I request all of you to join us next week, 24th. We are going to have hypertension only on the WHO guidelines, stage 1, stage 2, and the management. So I request all of you to join next week, Friday, same time, 9 to 10:30, and tell your friends also to join. And those of you who want to see the webinar, it is recorded. I'll share the link with you, all of you. And once again, on behalf of all of you, I thank our excellent speaker, Chennappan, for really an innovative type of talk with 10 positions and 10 points about the diagnosis. And I'm glad that many CVHOs who are doing day in and day out in the field. Chenipan, there are about 150 people, these cardiovascular health assistants in the country, who are doing pilot project on hypertension, following simplified protocols. Some of them have joined, so it will be very useful for them how to diagnose and how to do accurate blood pressure measurement. Thank you, Chenipan. Thank you, Manisha. Thank you, Sangram. Thank you,
sir.
Mega. And thank you, Anupam, for joining us. And we look forward to all of you on the next week. And of course, Chenipan is going to join us on the last webinar, which is a diabetic hypertension. So, but still, he'll be there here and there to give expert comments. If you have any questions, please put your questions to our chat box as well as in my WhatsApp. We'll try to get the answers for you. With this, I'll take leave from all of you. Take care, stay safe. Good night. Good night. Good night, all of you. Thank you.
Thank you. Thank you so much, sir.
Thank you. Thank you. Good night, man.
Good night, sir. Cheniappan sir. Good night.
Good night, sir. Good night, sir.
Good night.
Sangaram sir, Murugan sir,
Good night.
Dr. Mega. Thank you. Thank you. Thank you so much.
Thank you, sir.